All right. Well, good morning, everybody. Thank you for joining this conversation on medical respite care. I know some of you probably come to this meeting and you know exactly, or this conversation, and you know exactly what that is. And then for others of us, maybe it's a new idea or a new program. So our goal over the next 15 minutes or so is to just talk a little bit about medical respite care, talk about why we're having this conversation in the first place and what we're hoping to accomplish. And then really what we're hoping at the end of this time today is that we can hear from you. We really just want to hear what needs do you see? What needs have you encountered around this? And use that as we move forward with trying to ultimately put together a draft plan for how we could bring medical respite care to this community. So this conversation started for a number of reasons. One is flowing from our recently completed strategic plan. So last fall, our general membership, the Continuum of Care Board of Directors, along with a number of community partners, adopted a strategic plan to guide us over the next 5 years. And the third strategy in that plan, I could give you a whole 20-minute overview of the whole thing, but I don't think anybody really wants that at the moment. But the third strategy in that plan is all about how do we work with other systems? How do we help foster connections so that people who are experiencing transitions in any part of their lives don't end up experiencing homelessness ultimately? And one part of that is around building capacity, particularly around medical needs. And so in the third strategy, the goal is to create a countywide coordinated response to homelessness to minimize duplication of effort and improve system effectiveness to reduce homelessness. And then if you look at the plan underneath that, you'll see that one of the action steps is to improve discharge planning practices, ensuring access to medicine and appropriate supports for people experiencing homelessness, and then to specifically create 10 units of bridge housing with integrated case management for those discharged from hospitals and treatment facilities to ensure stability during a transition into housing. So this came out of all the conversations that we had really over the last year and a half, 2 years around needs that people see in our community. This transition in particular was one that people elevated and said, we need something here. You know, what exists is really not adequate to meet the needs in our community. So with that in mind, earlier this year, the Illinois Public Health Institute released a capacity building grant opportunity. And we applied for it and ultimately got the grant. So over the last couple months, we've been receiving technical assistance. We've been participating in a learning cohort to learn more about medical respite care, and then to really think about how we can build capacity as a community to actually bring medical respite care to our community. So currently in the state of Illinois, there's really only a few communities that have medical respite care, and all of those communities are outside of Chicago. So there's a couple communities that are downstate that received this grant that are working to go through this capacity building process, and we're one of them. So you being here today and participating is ultimately a part of all of that. You know, there's some things that I think we know, things that, again, I think were surfaced during the strategic planning process that are not unique to our community. Hospitals across the country, are often, particularly emergency rooms at the front lines of providing healthcare for people who are experiencing homelessness. And, one of the things that we've really sort of rallied around as a community the last few years is to recognize that housing is ultimately healthcare. It's really incredibly difficult, to improve your mental health, to improve or to take some forward on a journey around substance use, and even our own physical health is greatly impacted by the experience of homelessness. So the housing and healthcare are intricately linked. And we as a community, historically, part of the impetus for developing the strategic plan was a recognition that we've not come together to address homelessness in the way that we need to, and we have to take steps forward. And the reality is that not addressing homelessness effectively is incredibly costly for a community. Some research studies suggest that to provide emergency shelter, to provide emergency room care, and police response, and all these kind of different things that often result from homelessness not being effectively addressed, and supportive housing not being developed, can cost about $40,000 per year per person. And again, out of the strategic plan, one of the things that we're communicating is that for us to support a household in supportive housing costs about $13,000 per year. So we as a community, by addressing homelessness, we can provide better care for people who are experiencing crisis in our community. And we can do it in a way that ultimately creates other benefits for our community too, because it's more cost effective, and it ultimately creates a healthier community in all kinds of ways. So all of that is kind of underneath the surface as we have this conversation. We know that people who are experiencing homelessness, this is a part of a national study that is dated. It's 20 years old. It's likely that these numbers are probably higher since then. But the length of stay through this study is about 4.1 days longer than a person who has stable housing. A person experiencing homelessness is 3 times more likely to have emergency department visits. The 30-day emergency department readmission rate is 6 times higher than a person with stable housing. And then the inpatient readmission rate is 2 times higher. So, again, one of the things that's important about that is, as a community, these statistics, we don't have this level of data for our community, but surfacing from the strategic plan conversations, we know this is a need. We know from those that are on hospital staffs that they're bumping into challenges, working to help a person discharge. And all of that is really where medical respite care can come into the picture. Again, hopefully provide better care for the person who's experiencing homelessness, but also provide support for those providing healthcare in our community too. To deliver this better care at a more cost-effective way that ultimately has better outcomes. So, looking at this more, the reality is if we don't have medical respite care in our community, the need is still there, and people are still trying to navigate services and discharge planners and shelters, and all these folks are trying to provide the best care they can. But results from that is ultimately not the best outcome for the folks experiencing homelessness in our community. And so one of the pieces behind the initiative to create medical respite care is to create programs that have a high standard of care. And so part of what we hope to create is something that would adopt these national standards. And as you see here, components of a high quality program include safe and quality accommodations, environmental services, safe care transitions into medical respite, high quality post-acute clinical care, care coordination and wraparound services, safe care transitions out of medical respite. And all of this is driven by quality improvement, right? What are we doing? How can we do it better? In the absence of medical respite care, there's all types of strategies that are used. People are put in hotels temporarily. People are brought to an emergency shelter, even though there is not the level of medical expertise or other expertise to deal with some of the challenges that they're faced. And so it creates strain, all across organizations. And at the end result, there's a person at the center of that who's not receiving the care that they need. So again, what is medical respite care? That's maybe a better place to start. But the definition is acute and post-acute care for people experiencing homelessness who are too ill or frail to recover from illness or injury on the street or in shelter, but they're not sick enough to warrant hospital level care. The definition continued: short-term residential care that allows people the opportunity to rest, recover, and heal in a safe environment while accessing medical care and supportive services. It's not a skilled nursing facility. It's not a nursing home. It's not assisted living. It's not behavioral health step down or supportive housing, right? So it kind of occupies this really unique space in the overall system. But it is a space that we've recognized doesn't exist in our community. These programs that exist across the country, they look a lot of different ways, a variety of different bed numbers. Again, flowing out of the strategic plan, we're looking at creating a pilot for 10 beds. They vary on facility types. Where are these beds located? What does that look like? The length of stay. Some programs are 60 days or less, but there's a variety of different ways that programs are structured. And then in a moment, we'll look at some different models. Depending on the model that we ultimately decide to pursue, it has a significant impact on staffing that's needed and services associated with that, and the cost of the program. How can we fund this, and who can we get to come alongside us and make this a reality in a way that's sustainable? Admission criteria. Again, that comes back to the models that we'll look at in just a moment. And again, what medical respite is not. The reality is there's needs around skilled nursing facilities and nursing homes and assisted, all of these things are needs in our community. But with that being the case, it doesn't mean that medical respite care is the appropriate place for all of these needs to be addressed. And then referral sources. So how are people referred to this program? That looks a lot of different ways in communities too. Sometimes depending on who funds the beds and pieces like that. So there's a lot of different ways that these programs can look. And so what we're hoping to do through this conversation, through some surveys that we'll talk a little bit later, and by just continuing to work on this over the course of the next few months, is to help us land on a pilot program that makes sense for where we are as a community, and that gives us the opportunity to get started, but also to evolve as we go along to ultimately meet the needs that our community has. Part of what is included in medical respite care are these things: clinical care, case management, self-management support, and integration into primary care. How people get connected to each of these will vary on the model that ultimately we as a community decide to go with. Key components of a medical respite program is 24-hour access to a bed, 3 meals a day, transportation to any and all medical appointments, access to a phone for telehealth and or communications related to medical needs, safe space to store personal items, a wellness check at least once every 24 hours by medical respite staff. And again, depending on the model that we go with, that could be clinical or non-clinical. And then the types of services provided: care coordination, case management, medical or clinical care, medication support or management, and behavioral health care. The advantages, I think we've kind of touched on this earlier, but just to sort of spell these out a little bit more, it offers a safe and cost-effective discharge option. This is important in our community. It's important for our hospital partners. It's important for those who would like to get out of the hospital but don't have a safe place to go. It connects vulnerable patients to a broad range of community care and public benefits. It improves health by addressing the most immediate health care and social needs. It develops more comprehensive care, a more comprehensive care plan, and coordinates care across venues. And it provides time and space for healing and health education. These are the 4 key models. And so I tried, in developing this slide, I tried to sort of communicate with the colors getting darker, that with each next level comes more intensive services, more cost for staff, and more services that are provided ultimately. So I'll kind of read through these to give you a feel on this. Often, I think what communities do, we could start anywhere. We could say, hey, this is the most important need for our community, and even though it's the most intensive model, we're going to start there. What many communities do with the pilot is to start with a lower intensive model and then build from there, especially in a community like ours that has recognized that there are challenges across the system, particularly how does the medical system work hand in hand with the system to address homelessness, and how do we share data, and how do we make good referrals, and all of those types of things. We need to build capacity around that as a community. So jumping into the most comprehensive model may not be the best approach for us out of the gate. It might be something that we have to build our way to. The least intense model is what's called the coordinated care model. And in that model, the focus is on individualized case management and really facilitating connections to community-based services. So one of the things that we say about our community is that we're resource rich. We have great partners throughout our community. So in this model, we'd be saying there's case management, it's individualized, and we're going to help connect people to all the things that are available to them already in the community. The coordinated clinical care model is the next model in intensity, and it has many of the same things: individualized case management, additional services offered through community connections, but it also offers basic on-site medical services. So again, staffing is impacted by that, cost is impacted by that, but it makes more services available right there where a person is located. The next model is the integrated clinical care model. That model is, again, individualized case management and then on-site clinical supports that address acute health needs, and then additional services offered through community connections. So there, again, it's kind of the next level. We're bringing more things into the facility as opposed to connecting people outside of the facility as a way of bringing that care closer to them. But the staffing and cost associated with it takes another bump up. And then the most intensive model is what's called the comprehensive clinical care model. The focus is on individualized case management, on-site clinical supports that address the acute health needs of program consumers. But this model is also able to support more intensive medical needs and treatments on-site. Could be substance use, behavioral health, mental health, all of those types of things. Different level of care is provided around all of that here in this model. And then still additional services are offered through community connections. So you can sort of see that, the reality is there's need across the spectrum. One of the questions for us as a community is really, how can we get started, and then how can we scale this in a direction that ultimately helps us to meet the gaps that exist in our system. A visualization of sort of what this looks like, how it could make a difference for folks who are experiencing homelessness in our community, is, again, starts in hospital or ER, depending on what we decide on as a community. That wouldn't have to be the only referral source, but and then from there, people connect to the medical respite beds. They get that clinical care, case management, all of the things that we just mentioned in those models. And then in an ideal situation, our system would be effective enough to work with people who are in medical respite care bed to connect them with permanent housing. So instead of saying, we're trying to get you healthy enough that you can get into a shelter, ideally, we're going to work with people to say, how can we work with you from here to get you straight into supportive housing? In the event that we don't have enough supportive housing opportunities, the end result will be temporary housing. So that could be emergency shelter, transitional shelter housing programs, things of that nature. Okay. All right. I'm going to leave that one up. I know I ran through a lot there in 20 minutes, but why don't we start with, I'll stop sharing my screen. That way, if we have questions, we can see each other. But we'll make some space for any questions. And then we'd love to kind of make some space for you all to talk about the needs that you see around this, and go from there. So feel free to come off mute and start with any questions. I'm opening up the chat here.
Hi, Josh. It's Claire. I put a question in the chat.
And yeah, that's a great question, Claire. I don't think so. Some of that would depend on, probably not in that situation that you mentioned there. That would not be a barrier to service. But there could be other things that are barrier to service depending on where the beds are located. And so that's something that as we develop the program model, would all have to get spelled out. And then once we get to the point of deciding what will this facility or this model, how will we house it? Where will these beds be? That might determine other parts of that. But the goal would be more of a non-congregate setting, which would open up a lot of flexibility to serve people.
Thank you.
Any other?
Yeah, good morning, and thank you very much, Josh, for that presentation. My name is Akindele Adaramola. I'm the Chief Medical Officer at Springfield Memorial Hospital, and I'm here with, I think, a lot of people from Memorial here because this aligns very much with Memorial's mission of improving the health of the communities we serve. So when Becky tagged us on about this project, we were very excited, and which is why we're here today, to learn more about it and see how we could collaborate to make this a reality. So I think that's just my major comment first, to say this is quite an exciting news to know that it's a challenge that we face as we care for patients in the hospital who we know that they need something more than just, like rightly, there's a slide there that shows it very clearly, not seeking up for the ECF, for the SNF, but also, well, kind of not well enough for a typical shelter, which is what need you're trying to meet right now with this. So this is quite a need that I think we agree that our community needs, and we're better off to have this. I think the slide that, you show the continuum of the options of intensity of what this could be. I think those are decisions that probably you will arrive at, or will arrive at, as we keep on looking at what resource we have in our communities and who is doing what. So an assessment of what other, different programs already exist, which, as you also highlighted there, some of these things will be things that other people probably already provide. So we can see how there could be linkages where, if there could be a good connection with other programs, then there's a possibility to be one program that can be all things to everybody. But at the same time, this is Springfield, Illinois. So being cognizant of that, we probably will need to do an assessment and inventory of what other people have. And that will help to be able to see how the specific mission of what this is supposed to be will not be diluted by the fact that we're trying to meet every need that is possible. So that'll be my brief comment, but just to say again that we are very excited about this because this aligns with what we are about. So thank you.
Yeah, thank you. Thank you for joining, and thank you for that. Ramona, I see your hand up. Would you like to go?
Sure. So this has been a while back, but there was a couple close to downtown Springfield. I could see that it was a man and a woman. The woman was having a seizure. I stopped, called 911. Where I'm getting at is I'm wondering about the role of an advocate in this process, because we all have our own biases, and I think the police arrived, and and then the ambulance got there, and she was taken to one of the ERs, and I'm sure because of ambulance policies, he could not be with her in the ambulance. So I took him in my car to the ER. And then she received treatment and a prescription, but there were no funds for, it wasn't very much, it was like $3 or $4, but there were no funds for that. So I took them to Walgreens or wherever it was, CVS, I think it was, and we I paid for the script. And then at that point, I really had nowhere, to take them. And they gave her a referral. I think it was to, is it the St. Clair Clinic or something like that? So what I was wondering is, I think, I know I had a wonderful social work professor that, taught me decades ago that she never sent someone to the public aid office alone because, understandably, I mean, the police and the emergency room staff, they brush against some pretty rough folks at times. And, sometimes there's some levels of alcohol and drug use involved, and the interactions may not fall within what we consider, appropriate social norms sometimes. And so I'm just wondering, in this whole process, I would have been happy to have done more, but I felt like I did what I could.
Yeah, I mean, I think you do a really good job there, Ramona, kind of capturing how complex this all is too, right? We can run through these models and it seems really straightforward almost, but the reality is that, what you as an advocate or what, emergency room staff or our shelters are working on, often it's layers of complex challenges that people are facing. So I think the other thing that's important, as we get to model development, right? So like right now, there's a lot of questions to be answered, but how do we help people understand what this particular program can offer? And then from an advocacy standpoint, if you think it's something that a person could really benefit from, how can you help walk with them towards that? Those are all really great things to keep in mind as we work on really kind of developing what the pilot looks like, and especially what are the doors into this program? Is it only through the emergency room? Are there other ways for people in the community to recognize that a person is in a temporary housing situation that ultimately doesn't help them meet their physical health needs? So there's a lot. I guess in response to that, which again I think it's a great picture of how complex the challenge is. There's still a lot of questions that we have to sort of sort through, and I suspect as we launch the pilot, when we get to that point, we really need to treat it as an iterative process where we're recognizing there are going to be more complexities to it that pop up that we need to be able to be flexible enough to work with as we adjust the pilot.
And I do sincerely believe that everybody that was involved in responding did their very best. It's just a difficult situation and then I know once you get some of these things, developed, like, if it's a matter of, an agency doing this, whatever, then you get into issues like, I was just acting as, a community person. Then you get into issues of, can you transport someone because of liability? So I'm thinking about, how we could, because, you can give someone, had a prescription, we could take care of that, and then a follow-up, but then who would help with the follow-up?
Yeah.
And obviously somebody who's actively, I think she was having seizures fairly frequently, would probably, would need something like this.
Yeah.
So anyway, that's all. Thank you.
No, thank you, Ramona. Let's open the floor for, it doesn't just have to be a question about what's presented. Any comments? What do you, I know we have a variety of we have the health department and Helping Hands and Goodwill. We have a lot of Memorial Behavioral Health, I see. So a lot of different partners on this call. Any thoughts about what you see around this? What you could see as being beneficial to you and your organization as you try to help and serve people?
Well, I'll share. So this is something that we deal with on a daily basis. We're frequently getting people that are discharged either to Helping Hands or directly to the street, and they show up at Helping Hands from hospitals, inpatient institutions. And we have struggled over the last several years to meet those needs. But at the same time, we recognize they have nowhere else to go. And so Helping Hands is kind of pieced together the first two levels of these models. So we started with the coordinated care, really just doing case management and reaching out to community partners. As that's gotten more intensive, we've kind of gotten to that coordinated clinical. We've got a medical clinic on site. We've brought in other partners through the hospital systems and through like St. John's College of Nursing. And so I personally feel like we're kind of at that level already. I think we could get more buy-in. Our staff are we're not licensed for this kind of work. When you're talking about dealing with someone with incontinence issues or fall risks, if we don't have CNAs on staff, we're really not in a position where we could or should be helping. But if there's nobody else doing it, we step up. And so for us, what we would really like to see is that non-congregate medical respite facility where it would be a safer place for people to convalesce. you know, if somebody has open wounds, that's not, a shelter is not a safe place, no matter how clean we keep it when you have a variety of people like all together. And so, you know, I kind of came into learning about the medical respite because this is a need that we see, and we have so many resources in this area that I think that if we come together, we can make it work.
Great. Thanks, Laura.
Hey, this is Kendra with Memorial Behavioral Health. How are you doing?
Hey, Kendra.
So one of my just ideas that popped into my head, I'm walking by a street, my bad, is because we see a lot of people who have developmental disabilities as well. And so that leads them to not be able to take care of themselves. And so I don't think that this program specifically would help with that, but more services for that population is what I want to see.
Yeah. Yeah. Thanks, Kendra. Anybody else, around? Go ahead, Ramona.
So I just had a question for Kendra. Are the people or the individuals with developmental disabilities, are we talking about people that are not hooked up with the division of I forget what it's called, developmental disabilities or DRS? Are we talking about people that are not connected with those resources either?
They are dual diagnosis with developmental disabilities, and a lot of times they suffer from some type of mental illness as well.
Okay.
So
what does the state, where does the state usually, where would they lie in terms of services? Would that be the Division of Mental Health or DD?
it's more they need the case management, but case management is like on a wait list. So we just don't have enough. That makes sense.
You were cutting in and out. So you're saying at the state level, the wait list for them to get support is extensive.
I'm talking at Memorial's level. I haven't looked too much into the state level. Yeah. Because I know that we have case management that would help them immensely, but we just don't have enough people.
Okay.
All right. Well, just a few things here. Our hope is, we're going to put this recording out. We're going to send an email out with additional resources. So some documentation on those models. It'll spell it out, much more effectively than I did, as well as some other things. So all of that's going to come out in our general membership email list later today when we get the recording online. But there's a couple other ways that we want to, over the next couple weeks, next month in particular, continue this conversation, at least to get us to the point of having a draft plan to work with. So, Jamie, do you want to talk for a moment about the surveys?
Sure, thank you. I'm actually going to link them in the chat right now, but really we're kind of looking for additional input from the community and wanting to gather more input for those working with the homeless population regularly. So we created 2 surveys, one being more service provider, so shelter staff, outreach caseworkers, along those lines, and the other survey being more hospital staff. So I will link them, and we will include them also in the little email newsletter that's coming out. But please, if you can, send them to whoever you feel is appropriate. That way we get a good set of data from that. So
yeah, thank you. Yeah, so we're asking folks to pass those around. We're hoping to get some input through those between now and June 1st. On June 1st, too, on that afternoon of that day, we're going to kind of host a similar conversation for people who are involved in discharge planning of any kind. So whether you're at a medical facility or a hospital, or you're at a shelter and you're often working with people who have recently been discharged, sort of the same thing. We want to get a group of people together to just really kind of talk about that, because one of our goals through this is not just to move forward with the medical respite care piece of it, but also to develop a discharge planning task force that initially would be really focused on healthcare entities, but the goal eventually is get to a point where this group is working across multiple systems. So could be, a hospital, could be the justice system, with just pulling together that expertise in this community, but also making sure that, from our standpoint as the system to address homelessness, that we're providing the best information we can and the best resources we can, especially as we hope to grow our system frequently and especially over the next 5 years. So we're going to send information out on that discharge planning conversation in the email today too. And then at our June general membership meeting, we plan to make a presentation on a draft of a model. So some of these things that we talked about over the next 4 weeks, we're going to be using this information we get to kind of put together a model that then we could start to work with, to tweak on it from there, and then ultimately to talk about how we can make it a reality in our community. So over the next month, those are some additional things that are happening, and we'll send all that information out to the general membership. But with that is all that we have for you today. So we won't take up any more of your time than necessary. But if there's anything else anybody wants to add, we'll give you a last opportunity to do that before we set you all free. All right. Well, we're excited to start this conversation. We're excited to work with you all, and really grateful that you joined us today. So we look forward to keeping the conversation going. Take care, everybody.
Thank you.